which can generate beta cell formation. So there's a decline in progenitor cell and there's an amyloid deposition. Let us look at the proinsulin. If you look at this slide, the lower part of the slide, it shows the insulin level and the proinsulin level, and as the duration of diabetes increases, you find there is a steady increase in proinsulin level. And what does this proinsulin do? It increases insulin resistance, it increases coagulation, it can stimulate adipose tissue, and is a marker for apoptosis and also contributes to apoptosis. So proinsulin itself is an independent risk factor for cardiovascular disease. If you look at all the different OHAs that have been used and looking at cardiovascular mortality vis-a-vis the proinsulin-insulin ratio, you find, if you see, the first panel is only diet, subsequently is metformin, but the moment sulfonylurea comes, the ratio, proinsulin-insulin ratio increases, and as you go down, metformin, glitazones, it comes down. These gliptins are not there shown in this slide. So basically, all drugs except probably metformin and glitazone are beneficial. The GLP-1 and the DPP-4 has been shown to give you an alteration in a favorable way for the proinsulin-insulin ratio. This was a Mexico City study where the high proinsulin-insulin ratios, and what they showed was that glitazones significantly reduce the proinsulin-insulin ratio, beneficial. Lipotoxicity, prolonged exposure to high levels of free fatty acid impair beta cell function. And how do they do that? The PPAR gamma expression is suppressed by higher concentration of free fatty acids. And that does not, the PPAR gamma expression is not suppressed by high glucose, but by high free fatty acid content. And the FFA also produces deleterious effect on beta cells by inhibiting glucose-stimulated insulin release by 80%. So just having excess free fatty acids around the beta cell or in the beta cell reduces the glucose insulin stimuli release by almost 80%, as well as it reduces the islet insulin content by 75%. Glitazones prevent all of these damaging effects in vitro. As the duration of diabetes advances, you find that there is amyloid deposit. Amyloid is a polymer which is toxic to the beta cells, and you find amyloid being deposited there, and the degree of amyloidosis correlates with the duration and severity of diabetes. Probably the only drug which has a beneficial effect is a glitazone, which decreases the prevalence and severity of amyloid in beta cells. The decline in progenitor cell in animal studies has been shown to be treated with glitazones. This is a study in Zucker mice. These Zucker mice are genetically primed to become diabetic. Look at the first panel, the control panel. At 12 weeks, you look at the kind of beta cells which are left, and at 16 weeks, there is hardly any beta cell left. But if these rats or these mice are given glitazones, there is a significant preservation of the beta cell. So how do the glitazones preserve the beta cells? With a direct effect on the beta cell, amelioration of insulin resistance, reduction in plasma free fatty acids, mobilization of toxic lipid metabolites out of the beta cell, reversal of glucotoxicity, improving the proinsulin-insulin ratio, and decrease the prevalence and severity of amyloid in the beta cells. What proof do we have? The ADOPT study. What was the ADOPT study? The ADOPT study was a 5-year study done to look at monotherapy in type 2 diabetes, where they used glibenclamide, sulfonylurea, metformin, and glitazone. And at the end of 5 years, they found that the maximum number of patients who continued to be controlled were on a glitazone, and the least number of patients were on glibenclamide. What does this tell us? That of these 3 drugs, the glitazones preserved beta cell the maximum as compared to the others. This was the Chicago study where they compared glimepiride with pioglitazone over a 72-week period. In the first 16 weeks, Glimepiride was superior in controlling the blood glucose as compared to pioglitazone. But after 16 weeks, by 72 weeks, the glimepiride effect was wearing off. But the glitazone effect still remained. What does that tell us? Simple, that the glitazones preserved more beta cells as compared to the sulfonylurea. Then we have the GLP-1. Dr. Shailaja Kale gave a very eloquent and informative talk. GLP-1 has been shown to stimulate beta cell regeneration and mass because it can cause a beta cell neogenesis, beta cell proliferation, and beta cell hypertrophy, and reduces beta cell apoptosis. Now, all these studies have been done in neonatal mice. This has yet to be conclusively proved in humans. This is the effect of GLP-1 beta cell mass in Zucker diabetic fatty rats. If you look at the beta cell mass, GLP-1 increases, beta cell proliferation is increased, and beta cell apoptosis is significantly decreased. So in cell cultures and animal studies, exenatide is the GLP-1 analog. Increased expression of key beta cell genes, increased insulin synthesis and processing, increased beta cell mass with increases in neogenesis and proliferation, and reduces apoptosis. In humans, exenatide improves pro-insulin-insulin ratio, very significant, which I told you earlier. There are only two classes of drugs which do this. They are the PPAR gamma agonist and the GLP-1 analogs and DPP-4, which have a good effect on the pro-insulin-insulin ratio. It restores the first phase secretion, augments insulin secretion at lower prevailing glucose concentration. Liraglutide is another GLP-1 analog which has also been shown to have similar effects. The incretin enhancers, that your DPP-4 inhibitor, sitagliptin, if you read the last one in yellow at the bottom, reduce pro-insulin-insulin ratio and significantly suggest improvement in beta cell function. And similar findings are seen with vildagliptin. Basically, these findings would be seen with most of the DPP-4 inhibitor. They are very similar. As a class, it has an effect. There are other methods that lead to short-term improvement of beta cell secretion. Weight loss. If you have weight loss, look at the first panel. The green, this is the glucose level on the first panel. The green is showing before weight loss, and the orange or the brown one is after a weight loss. In the before, the BMI was about 35, and after the BMI is around 29.5. Look at the glucose levels, they are very high. The insulin, before and after. But if you look at the insulin secretion, the before it was down, and after weight reduction, the insulin levels have significantly gone up, telling us that there is some benefit of exercise and this. Probably with exercise, weight reduction, insulin resistance comes down, and that could be one of the mechanisms by which the beta cells are doing much better, because insulin resistance itself is a major risk factor for beta cell apoptosis. Metformin shows very similar thing, but there is no change in the insulin levels. What does that tell us? That metformin is beta cell neutral. Neither does it damage beta cell, nor does it enhance the beta cell and reduce the apoptosis. Glucotoxicity. Whenever there is glucotoxicity, you will find the blood glucose going up in the upper panel, that is before, and the lower panel, once the sugar is controlled, the glucotoxicity is removed, you find the insulin levels come up. So glucotoxicity is another important thing. So good control of sugars itself will preserve beta cell more. And there was a question whether sulfonylureas destroy beta cells. See, I showed you the first slide on UKPDS. Without anything, there is an apoptosis which goes on. Sulfonylureas, I don't think they destroy the beta cells by themselves. But what is seen is patients who are on sulfonylurea, when you compare it with a glitazone or a GLP-1 or a DPP-4, their beta cell apoptosis is much more. That doesn't mean that sulfonylurea per se is killing the beta cells. It means that the glitazones and the GLP-1s are preserving the beta cells better. So besides glucotoxicity and insulin resistance, treating insulin resistance and glucotoxicity, do we have anything that can preserve the beta cells? You have oral insulin sensitizers, you have a GLP-1 analog, and you have a DPP-4. As of today, as of today, the only drugs which we have which are beta cell friendly are the glitazones and the GLP analogs and DPP-4. What are the futuristic strategies for beta cell preservation? There are newer PPAR agonists in the pipeline and a whole host of them. You have the TZD, that's the PPAR gamma agonist, a whole list of them. I'm not going to go into that. You have the dual PPAR gamma, alpha and gamma. Alpha is more for lipid control, gamma is for sugar control. So you have a host of molecules which are being worked out, and now you have a triple pan-PPAR agonist, which is alpha, gamma and delta. Your gamma is anti-diabetic, alpha reduces lipid abnormalities, and delta, besides lipid lowering, can also help in weight reduction. So if you have a molecule like this which has got a pan-PPAR agonism, it could be beneficial from all aspects. And this triple PPAR agonist, there are many of them in the pipeline. And there is a further development of what is known as a selective PPAR modulator, which is a SPAM. What is a selective PPAR modulator? The objective of developing this selective PPAR modulators was to minimize the adverse effects of glitazones. What are the adverse effects? You have fluid retention, obesity, and so on. To retain the benefits associated with conventional PPAR gamma agonist, SPAM activates selective insulin signal, but not all adipogenesis PPAR gamma signaling pathways. There is a new molecule which has come, which is called mTOT, which is in the news in the last 1 week, which is a variant of SPAM, which acts through the mitochondria of the cell rather than the nucleus, and showing to have very decent effect without the side effects of a PPAR gamma. So SPAMs also, there are a whole host of SPAMs which are in the pipeline. And what do SPAM do? They're selective gamma modulator, which just have a good glucose lowering effect and a lipid lowering effect as compared to TZD or the thiazolidines, which have glucose lowering, adipogenic and edema and other effects. Stem cell is very much in the news. And in fact, you have a lot of people advertising on the net that stem cell therapy for diabetes and type 2 diabetes and type 1 diabetes and permanent cure. And there are patients who come and ask me, what is to be done? And I'm sure they must be asking you also, especially type 1 diabetics. The parents are very worried about their child, sir, stem cell. And if you just do a Google search, you will find so many people are offering stem cell therapies for diabetes. So what is this all about? What is a stem cell? Basically, if you look at this diagram, once fertilization of the ovum takes place with the sperm, the fertilized ova begins to divide, 2, 4, 8 and so on, and it forms the morula. The fertilized egg forms the morula, and then you have the blastocyst. This blastocyst, see, till the morula, that can form the complete fetus. The blastocyst, if you see, will form the complete fetus. The trophoblast, the sac-like structure that you see, forms the placenta. And what you see inside the inner cell mass is what differentiates into the different parts of the body. The endoderm, the exoderm, the mesoderm. And they are the pluripotent stem cells. And I'll tell you what the potency-wise. What is a totipotent cell? Totipotent cell is once you have a fertilization of the ovum and the multiplication which takes place, that stage is the totipotent cell. It can form a complete fetus. A pluripotent cell is from the trophoblast, the inner cells are removed. Now these cells can differentiate into any organ, but they cannot form a complete fetus. That's a pluripotent. Multipotent cells, they can form one group of cells. Means multipotent means, like for example, hemopoietic stem cell. It can form platelets, it can form RBC, it can form WBC. But in the blood hematology series. And unipotent cells are ones which can form only the same thing. They cannot differentiate into anything else. Why is not moving? So you have the totipotent, where you can get the complete fetus. Pluripotent can go into any form. Multipotent, like I told you, is a blood stem cell which can get red blood cell, white blood cell and so on. But unipotent will be individual only, individual organs or tissues. So stem cell and diabetes, what is the future? Beta cells are not generated from adult stem cell in the pancreas. What is being done today is they just collect stem cell from the blood or the bone marrow and injecting into the patient and saying, oh, we are treating diabetes. So beta cells are not generated from adult stem cell in the pancreas. It is unlikely that a cure for diabetes will come from adult stem cells. Embryonic stem cells only can generate beta cells. And in fact, they have developed beta cells from embryonic stem cells. But they are not able to, those cells, they look exactly like the beta cells. They have insulin, but it doesn't have the sensors to secrete insulin when they have to secrete. And these cells, they keep on multiplying, and the possibility of malignancy and others keep coming in. So they have been able to form beta cells, but they are not able till today to get that stimulus where, depending on the glucose sensor is not there in them. So it is important to emphasize that hemopoietic stem cells would be unable to differentiate into any beta cell. So the task ahead today is guiding cultured embryonic stem cell to become insulin producing beta cells with a glucose sensor. Currently, stem cell therapy is established for which condition? Only for bone marrow and hematological malignancy, nothing else. Other stem cell treatment are still experimental. This means that it has not yet been shown that this treatment is safe or that it will work. So most of these so-called stem cell therapies which are doing the rounds everywhere is just fooling the patient, fleecing, which is not the right thing to do. The other way of getting back beta cells is the pancreatic islet cell transplant or a whole pancreatic transplant. So you have a whole pancreatic transplant, islet cell transplant. What is the problem with this? There are not enough organs to meet the demand. And even if you do get an organ, you need to take powerful immunosuppressants which have their own side effects, own morbidity and mortality associated with surgery and the drugs. Injection of pancreatic islet cells, very tedious process to get the islet cells. Again, lack of organs available for getting the islet cells. And the problem is less than 8% of these transplants have been successful. And again, you need immunosuppressants in this case. To conclude, we have never seriously thought of protecting the beta cells. And if possible, to get back the lost cell by the therapeutic ventures. At the present moment, we have no strong therapeutic tool. But available tools like medical nutrition, dieting, weight reduction, exercise, minimal use of secretagogues, judicious use of glitazones and incretin mimetics from the beginning could possibly change the scenario. So as of today, what we have is only a glitazone and the incretin mimetics, exercise, weight reduction, good lifestyle. That's all that we can do. Good glycemic control to preserve beta cells. Thank you very much, ladies and gentlemen.
Thank you, Dr. Panikar. That was a very excellent deliberation on
Thank you.
beta cell preservation. The topic is open for some questions.
The question, if I heard it right, is if we start insulin from day one to preserve beta cell, will it help? See, in fact, last week there is a big article which has come that those people who are on insulin have greater complications, all-cause mortality and everything than those who are not on insulin. Number one. Number two, the origin study just came out in 1st of October 2012. What was the origin study? Same thing what you said. They believed that giving insulin early would do everything. No. 7 years they have given long-acting glargine insulin, and at the end of 7 years they found there was no difference between giving OHA or non-OHA or insulin. So giving insulin right from day one is not the answer. Insulin is not going to preserve the beta cell. Insulin will not treat insulin resistance. Insulin resistance itself is a risk factor for all cardiovascular problems. So you need to address the basic pathophysiology of type 2 diabetes. Giving insulin is only a replacement. It is not addressing the pathophysiology of diabetes.
So will it treat the glucotoxicity very early?
See, a newly diagnosed diabetic who comes to you with 400 sugar, you treat him with a simple sulfonylurea, metformin and even a DPP-4 if required. You can control him in 33 weeks absolutely properly. Absolutely no problem. But the point is, you need to address the basic pathophysiology of type 2 diabetes. Forget diabetes itself, forget beta cell. Insulin resistance is a risk factor for diabetes, for all the complications of diabetes. All the macrovascular complications are linked to insulin resistance. Insulin will never address that. It will not preserve the beta cell. But there are studies which have been shown from China that they could preserve beta cells. But his origin study has put to rest all that.
Thank you, sir.
Any other questions? Okay. Dr. Panikkar, do we need to redefine our approach to the patients of diabetes by targeting patients with impaired glucose tolerance more aggressively?
Ideally, yes. Because like I showed you, we have a huge number of patients who are in the pre-diabetic stage. We need to do something drastically. As of today, we do not have any recommendations on drug therapy for it. But if you ask me, drugs, a pio or a metformin would be ideal. But here, lifestyle modification, weight reduction, and I have shown you by doing that, you can get a lot of benefit in these patients. So aggressively promoting lifestyle modification, weight reduction may be one of the ways. But if at all you need to give a drug, you will have to choose between metformin, DPP-4 and pio, either a combination or one of them to in long term. But I suppose as data comes in, we will know. Among all the diabetes prevention programs, the best results have been where glitazones have been used. The tripod study, the pipod study, the DREAM study, all of them have shown the same thing.
Thank you. Thank you, sir. We close this session.
Thank you very much.
I request Dr. Deshpande sir and Dr. Shah sir to felicitate Dr. Vijay Panikkar sir. I request Dr. Wag sir to felicitate Dr. Deshpande sir and Dr. Shah sir. I request the delegates to join for lunch arranged in food court. Due to time shortage, we will meet soon after half an hour. After lunch, we are with Dr. Miss M.S. Hiremat, Dr. Shaileja Kare, Dr. Jayashree Todkar.
Goa.